My name is Dr. Sally Ayesa, and this is a short lecture on the imaging findings in COVID-19. Note that this is a constantly evolving and updating topic, with an ever-growing suite of resources and peer-reviewed articles becoming available online. I have referenced some such articles and resources throughout this presentation if you are interested in learning more. COVID-19 is the clinical condition which arises from infection with the SARS-CoV-2 virus, not to be confused with the SARS-CoV-1, which was responsible for the SARS outbreak in the early 2000s. SARS stands for Severe Acute Respiratory Syndrome, reflecting the most concerning manifestation of the disease. The most common clinical features are fever and cough, which are present in greater than 80 and 60% of cases respectively. Other common manifestations include fatigue, productive cough, and shortness of breath. Less common features include myalgias and arthralgias, headache, sore throat, chills, and pleuritic chest pain. Uncommonly, cases may exhibit GI upset, nasal congestion, heart palpitations, or chest tightness. Case reports have emerged detailing alterations in sense of smell. What you notice from these symptoms is that they are very nonspecific, with significant overlap with other respiratory infections. The definitive test for COVID-19 is real-time PCR. The current position statement from the Society of Thoracic Radiology is that routine CT screening for the diagnosis of patients under investigation for COVID-19 is not recommended. They recommend that CT chest can be restricted to patients who test positive and who are suspected of having complicating features such as abscess or empyema, that is, a complicating bacterial superinfection. The position in Australia echoes this, in that CT should not be a primary diagnostic or screening tool, and as such medical imaging does not form part of the current diagnostic criteria. However, as things develop and change, it is important that our clinicians are familiar with the imaging features of COVID-19 so that we can detect unexpected cases and assess those COVID-19 patients who do have imaging investigations. If you do order a CT in a COVID-19 patient, it should ideally be non-contrast. If abscess or empyema is suspected, discuss the case with the local radiologist or registrar, as contrast may be indicated in these patients. The chest X-ray and CT findings of COVID-19 are sensitive but not specific, with the imaging findings overlapping with a number of infectious and non-infectious conditions. In fact, many conditions which result in diffuse lung injury will have a very similar, if not identical, pattern to COVID-19. The patterns may, however, alert a clinician to the presence of infection. In patients with known infection, medical imaging will play a role in the assessment of disease severity, monitoring outcomes, and assessing the position of tubes and support lines in our ventilated patients. Let's start with the chest X-ray findings in COVID-19. This table summarizes the most common chest X-ray features present in patients with COVID-19. Note that 30% of patients in this cohort presented with a normal chest X-ray. Normal chest X-rays are more common early in the disease, with 1/3 of these patients going on to develop changes on imaging as their disease progresses. Other studies have reported that only 3% of chest X-rays in patients with severe disease are normal. In this cohort, just over half of the chest X-rays demonstrated peripheral consolidation, with the remaining changes described as ground glass. Ground glass is a term which is used frequently when describing cases of COVID-19, as it refers to an opacity through which you can still make out underlying bronchial or vascular markings, kind of like looking through a foggy shower screen. The distribution of changes is typically lower zone, or does not have any zonal predominance. Opacities were peripheral in greater than half of the cases, and usually bilateral, especially in the later stages of the disease. Pleural effusions are uncommon, and usually associated with more severe cases. In this example, there is bilateral consolidation, which is predominantly peripheral. It does not have a clear zonal predominance. Note that the costophrenic margins are sharp, indicating that there is no evidence of pleural fluid on these films. In this case, there is more extensive bilateral opacification. This could be described as ground glass, as the lung markings are still seen through the opacities, particularly more medially. Once again, the costophrenic margins are sharp, indicating the absence of pleural fluid. on this projection. This is another case of bilateral parenchymal opacities with a lower zone and peripheral predominance. Note that the changes at the left lung base are more dense in keeping with consolidation. This patient has more severe infection with bilateral lower zone and mid-zone patchy consolidation. There is also a left pleural effusion, which is seen by blunting of the left costophrenic margin. In patients such as this who have multiple tubes and support lines, it is also important to assess line position. This patient has an endotracheal tube, which appears in an appropriate position, allowing for mild patient rotation. Let's move on to the CT features of COVID-19. Ground glass changes predominate early on in the course of infection, with consolidation more common in the peak phase of the illness, which occurs around day 9 to 13. Bilateral changes is one of the hallmarks of COVID-19, however unilateral disease can be seen in a minority of cases, particularly in the early stages of infection. Later in the disease course, as ground glass opacities develop into more confluent consolidative changes, air bronchograms may become apparent. Interlobular septal thickening and crazy paving patterns are also more common in the latter stages of the illness, and we will see some examples of this in the upcoming slides. Note that a normal CT does not exclude the diagnosis of COVID-19, particularly in asymptomatic patients who are early in the course of their illness, where up to half of the CT images have been reported as normal in this group. Here are two cases of bilateral ground glass opacities. Note that you can still discern the pulmonary architecture through the density. The rounded morphology of the opacities, well demonstrated in this image on the right, is a common characteristic reported in the literature. Ground glass lesions may progress over time to become more dense consolidation, then exhibit organizing changes as they heal. Discrete pulmonary nodules can be seen in some patients, which reflects the more common pattern of bilateral rounded densities. The right case shows a more dense nodule, which maintains a ground glass halo, seen by the arrows. Nodules are more commonly multiple and bilateral, especially beyond the early stages of infection. Interlobular septal thickening reflects fluid and debris in the interstitial space surrounding the secondary pulmonary lobule. It is seen as lines within an area of ground glass opacification, seen here. Air bronchograms become more common in areas of developing consolidation where there is an aerated bronchus adjacent to the consolidated lung, an example of the silhouette sign. It is indicated by the arrows. Other findings which have been described include air trapping, local vascular thickening, and a reversed halo sign. The reversed halo sign is when there is an island of non-consolidated lung surrounded by the opacified lung, seen in the red box. This is a hallmark of a condition called organizing pneumonia. What we are seeing in the COVID-19 patients at this later stage in their illness is a near identical pathological process. The lung is organizing and healing itself in response to the insult from the virus and resulting acute lung injury. Fibrosis is the later stage of healing, the last stage of organization, which results in scarring. In the lung, scarring distorts the parenchyma and creates sharp lines, as seen in this image. In this case, the same patient has been imaged at day 1, 5, 11, and 15, exhibiting changes over time. On day 1, changes are bilateral, peripheral, and ground glass, with rounded opacities. By day 5, the changes are more confluent and have denser consolidation. Consolidation is denser still by day 11, with air bronchograms seen. By day 15, consolidation is improving and there is evidence of developing fibrosis with more lines and distortion as the lung heals. Pleural effusions are present in less than 5% of cases, more commonly in patients with severe disease. They may only be small. Mediastinal lymphadenopathy is atypical. Remember that the CT features of COVID-19 are sensitive but not specific. Any condition which results in a diffuse lung injury will result in a similar pattern of findings. Here are two examples. The pattern on your left has bilateral ground glass changes with interlobular septal thickening. This is a case of influenza A. The patient on the right has bilateral organizing changes with evidence of fibrosis and a reverse halo sign, which is seen here. This is a case of cryptogenic organizing pneumonia, which is an idiopathic inflammatory condition. For comparison, here is a case of SARS on your left and MERS on your right. The patient with SARS has bilateral ground glass opacities similar to those seen with COVID-19. The patient with MERS has mixed ground glass opacities and consolidation, with a peripheral and basal predominance similar to the common features of COVID-19 also. MERS is known as a more severe infection, however, with a much higher mortality rate than COVID-19. This may account for the greater severity of changes on imaging of this patient. We will finish with some practical tips. Advice from health authorities is constantly changing, so please refer to your local guidelines for the most up-to-date information. If you identify a suspected or confirmed case, please make sure that you take steps to protect yourself and other staff and patients. Place a surgical mask on the patient if it is available and isolate them if possible. Observe hand hygiene and don PPE if you need to interact with the patient closely or perform a procedure. If you identify concerning features on medical imaging, take precautions while you wait for the imaging to be reviewed and report issued. Concerning cases should be read by a radiologist, especially given the complexity of the findings, the broad differential diagnosis, and the implications. If you are concerned, it is best to contact the duty radiologist or registrar, but remember that radiology services may be similarly overwhelmed in the coming weeks and months. Remember that chest X-ray and CT findings are very sensitive but not specific, but given the current climate, it is best to have a low threshold for clinical suspicion. The guideline remains that real-time PCR from a swab is the definitive diagnosis. There are many excellent resources available to help with the medical imaging side of COVID-19. Radiopedia.org have an excellent summary and a suite of cases. RSNA have helpfully collated their articles and pictures into a one-stop shop. RANZCA have been working tirelessly to develop resources for Australian staff and guidelines for practice. Thank you to all of my radiological colleagues around the globe who are working to educate us surrounding this pandemic.